Good afternoon, everybody. Welcome to today's Transcend Seminar. We're glad you could join us, and it looks like you found the sandwiches. So if you didn't, they're still outside. So um, please feel free to help yourself. Today's presentation is titled Eating Disorders, Classifying, Clarifying, and Developing New Treatments. We're honored to have Dr. Stephen Wonderlich with us as our speaker. Dr. Stephen Wonderlich is the interim president for research in Sanford Fargo and the Chester Fritz Distinguished Professor in Psychiatry and Behavioral Sciences at the University of North Dakota School of Medicine and Health Sciences. He currently serves as a PI on the Center for Biobehavioral Mechanisms of Eating Behavior, COBRE, which is currently in phase 1 of funding. He has been continuously funded by NIH for over 25 years and has served as the PI on a variety of R mechanism grants over that time. Additionally, he served as the site PI in the Midwest Regional Postdoctoral Training Program in Eating Disorder Research, which is funded by the National Institute of Mental Health. The bulk of his funded research focuses on eating disorders, obesity, and bariatric surgery. He also serves as co-director of the Sanford Eating Disorder and Weight Management Center, which is a broad-based clinic and hospital program for individuals with eating disorders. He also was appointed to the American Psychiatric Association's DSM-5 task force, which created the current diagnostic classification for psychiatric disorders in 2013. Please join me in welcoming Dr. Stephen Wonderlich.
Thank you, Kent. This working okay? Okay. It's hard for me to come here today and not be flashing back, and I told some of these guys this, to like 1986 and 1987 when I was driving up 29 and going to Old St. Mike's Hospital and giving lectures in the auditorium there, and things have changed a little. And even when you built this new building, I was still giving lectures in the back, but this was new to me just in the last year, so this is spectacular. So, very nice, very nice. Well, let me just talk a little bit about what I'm going to try and do today. I've got a few objectives, and this is going to be a mishmash of stuff that I thought might be kind of broadly interesting, maybe clinically relevant to some of you, scientifically relevant. About halfway through where I want to get to is I want to review some clinical things about eating disorders, which are interesting, I think, and guide some of the research we do. But then I want to get into a particular program of research, which we started doing a long time, 20 some odd years ago. And it has produced some benefits that I think are, in terms of going from kind of, in the behavioral health world, kind of basic stuff into more translational stuff, and then into clinical work with randomized controlled trials and dissemination and implementation. I mean, we've dabbled in the whole range, and so it brings a lot of things together, and I think it's been an interesting story. So we'll start out just talking about the diagnoses. What are these things? And believe me, categorical diagnoses in psychiatry are a problem, especially in certain diagnoses, including eating disorders, but I'll show you what we currently have. I'm going to talk about one of the problems is when you put people into a box, it's very likely that their box is going to spill over into another box. And so you have what we call psychiatric comorbidity. The bulk of eating disorder people also have major depression. Well, that's interesting. What does that mean? We'll talk about some of that. Then we'll do just a quick look at a range of maintenance factors. I mean, a lot of people, they hear about eating disorders and they think, oh, sociocultural. Well, yeah, that's important, and I'll talk about that, but I mean, it's a brain-based problem. Anorexia nervosa is the most lethal psychiatric problem. Maybe some of the drug dependence problems are surpassing it, but it's a serious condition, and it's not a flash in the pan that teenage boys and girls get into and then get better. Sometimes it is, but often it's not. And then we'll talk about this treatment development stuff. This is a nice paper by Ulrika Schmidt from King's College. And she just kind of laid out a whole bunch of factoids, which I won't cover a lot of, but it's worth knowing about. Eating disorders. Peak age of onset, 15 to 25 years of age. There's talk about, is there a late onset eating disorder in some women? Maybe, don't know about it yet. Average duration of an eating disorder, 6 years, with a subgroup who will have this disorder for the rest of their lives, and they'll die young. Anorexia nervosa and bulimia nervosa, those are my acronyms throughout. I'll try and clarify those. Are more common in young women, but men and boys are affected. Binge eating disorder, another diagnosis we'll get to in a minute, is equally split between males and females. Eating disorders are increasingly diagnosed at younger ages, and colleagues of mine who work in hospitals are telling me they're admitting 9 and 10-year-old anorexic patients. Anorexia nervosa is one of the most common chronic illnesses of adolescents, similar in incidence to type 1 diabetes. Mortality rates for eating disorders are at least broadly twice the general population. Anorexia nervosa 6 times higher than the general population. About 20% of people with anorexia nervosa are likely to die within 2 decades of their initial diagnosis. 1 of 3 people with bulimia nervosa or binge eating disorder will become obese, which carries its own risks. 1 in 4 eating disorder patients is unemployed. In the Medicaid world that we're talking a lot about these days, that's a big deal for these folks. Women with eating disorders are more likely to stay childless, need fertility treatment to conceive, even after recovery. Women with eating disorders have significant problems feeding and interacting with their children. There is this question about, can you transmit it on to the next generation, genetically and non-genetically? Caregivers of eating disorder patients spend about twice as much time caregiving for eating disorder patients than patients with other diagnoses like cancer, psychosis, or dementia. It is a heavily family-intensive problem to have. These are teenagers often. Recent estimates are that in Europe, when she did this, 20 million people had an eating disorder at a cost of €1 trillion per year. A lot of hospitalization. It's not cheap. So that's just a background. Now I'm not going to spend a lot of time on these criteria. I want you to get your head around what it is. Anorexia nervosa, the starvation syndrome. We've seen some things about it. The Carpenters, Karen Carpenter was a kind of a case example years ago that connected the world to what this is. Restriction of energy intake leading to a very low body weight. And I'm talking about BMIs definitely below 18, well below 18, 10, 11, 12, 8, 9, 10. You see people extremely emaciated. They have an intense fear of gaining weight or becoming fat. It becomes their raison d'etre. I cannot gain weight. And they're pursuing exceeding weight loss even after they're emaciated. Disturbance in the way in which their body shape or weight is experienced, undue influences of body shape or weight on self-evaluation. My worth as a person is about my weight. Persistent lack of recognition of the seriousness of the condition. So in spite of the fact they've been in the hospital 6 times, they're still out jogging at 6 in the morning and then making sure they only eat grapes. That's the scenario. Another diagnosis, which kind of emerged more heavily in the late 70s, early 80s, the diagnosis of bulimia nervosa was first coined in 1979. This one, it's a little different. There is a type of anorexia nervosa that can transition into bulimia nervosa. They gain some weight, but then they start binge eating, which is the hallmark. And binge eating is eating a large amount of food in a discrete period of time, like about 2 hours, and it's more than most people would eat in 2 hours. So a lot of the people we see. I did a study at NDSU in 1980 something, and we found that 5% of the student body, female student body at that point in time, met our diagnostic criteria for bulimia nervosa. So it's fairly common. And back then, you know, the binges were like ice cream and cookies and donuts, things that, and we'll get to it in a minute, are somehow satisfying, but are also easy to get rid of. Because the other hallmark, I should say too, they have to feel out of control when they're doing it. It's not a pleasant eating experience. They feel compelled. They can't stop. Then a person with bulimia nervosa fairly quickly transitions into another phase of the episode, the purging phase. And it's vomiting, laxatives, diuretics, diet pills, enemas, suppositories, saunas, anything that helps them to feel like they are going to control and manage the calories they just ingested. Laboratory studies suggest the average size of a binge eating episode in someone with bulimia nervosa is about 3,500 kilocalories in about 90 minutes. That's a fair amount of food in 90 minutes. It has to happen at least once a week to meet these diagnostic criteria, and these folks are as concerned about body shape and weight as are anorexic individuals, and that's part of the whole pathology. Third kind of substantial disorder that became a full-fledged disorder in 2013 is binge eating disorder. And these are people who have binge eating episodes, kind of like the ones in bulimia nervosa, a few other criteria. In addition to eating rapidly or large amounts, they have to eat more rapidly, they have to eat until they're uncomfortably full, eat large amount of foods when they're not hungry, eat alone because of being embarrassed, and they feel disgusted, depressed, etc. So these are people that have eating episodes which are exactly what they do not want to do, but they keep doing it over and over. They tend to become overweight or obese. They have significant distress, and again, has to happen about once a week for at least 3 months. Those are the three main ones. There's three others that I'll just mention. Rumination disorder has been around forever. It's not a high-profile eating disorder. People swallow food, swallow it down, and somehow have the ability to bring it back up and then back down. And it is this up-down kind of cycle which they get caught in. And they can run into some serious GI problems. I treated a couple of people with this years ago. It's a very tough condition to impact because it becomes almost reflexive for them. Pica is just eating non-nutritive substances. Dirt, ice, paint chips. It's kind of weird. They'll go to a window ledge that has some paint and they just put something in their mouth. They don't know why they're doing it, but they do it, and it becomes a problem. Lastly, this last one, it's been introduced in the current diagnostic scheme as a full-fledged eating disorder. We frankly don't know what it is. We used to think it was anorexia nervosa. These people are very thin, like anorexic people, but they don't have this, seemingly, they do not have a concern about body shape and weight. They're not afraid of fatness like anorexic people are. There's other reasons they won't eat. They might have had a choking episode and they're afraid to swallow. Some just do not have an interest in food. Some of them clearly are kind of on the autistic spectrum, and they might not want to eat anything unless it's brown. And so that kind of narrows it down, and they get very emaciated. I was on this committee, we're working on anorexia nervosa, and a bunch of pediatricians came to us and said, hold on, because there's something else going on out there. I got a lot of these kids in my practice, and they're not afraid to gain weight. They just don't want to eat. And so it got thrown in as a category. Frankly, it's kind of a mess right now. It needs some empirical work to clarify it a bit. So let me shift gears now away from the actual diagnoses, because the diagnosis itself is rarely the only condition. So this is a table I built. Let me see, how did I do this? Okay, so the numbers on the left side, not in parentheses, was the median across whatever the number in parentheses, that's the number of studies I looked at. So, for example, ANR is anorexia nervosa restricting type, and across 5 studies, the median rate of depression was 40%. The next category over is anorexia nervosa, the binge purging type. That's the one that you get a little bit of everything. Across 5 studies, 73% of these people also met criteria for a major depressive episode. Bulimia nervosa on the far right, about half. So I put a few in red that are kind of theoretically interesting. Some people think eating disorders are just variants of depression. There sure is a lot of depression in there. Some people think anorexia nervosa, whether it's restricting or binge purge, is a variant of obsessive compulsive disorder. That's the second row. You see the rates. They're not through the roof like depression. There's a little more elevation of OCD in the restricting types than in bulimia nervosa, but not much. Social phobia, about 20%. Panic is, I just remember doing intakes, and panic disorder was not a thing that we saw a lot of occasionally. Substance use, basically, most of us, I would say, the data don't support it tremendously, that if there's a binge eating element, you should see elevations in substance use. So bulimia nervosa, the binge purge type, and you see it's a little higher than the restricting type of anorexia. I do think there is something about the ability to ingest large amounts of food the way they do, and the temptation, if you will, or the propensity to overconsume substances of any kind. Phobias, a little bit here and there. So, quite a bit, but then this question I think is the important one, especially clinically. Do they have a complex array of psychiatric comorbidity that's important? And this is a study, the National Comorbidity Survey is a very well-known epi study done in the US by a group at Ron Kessler at Michigan. And they did, eating disorders doesn't usually make the cut on these kind of things, but they started to. And they asked the question a little bit about what's it like to have comorbidity in the eating disorders? And what they came away with was this. Those are the 3 eating disorders across the top: anorexia nervosa, bulimia nervosa, binge eating disorder. And then how many of them had exactly one psychiatric disorder in addition to their eating disorder? How many had 2? And how many had 3 or more? And the take-home message is, and if you think about this, it's just additive. Look at the 3 or more category. Half to 2/3, just a third in restricting, have 3 more disorders on top of their eating disorder. So an eating disorder, depression, an anxiety disorder, and a substance use disorder. You got all that going, that's a complex array of psychiatric problems, and it doesn't bode well. The simple story at the bottom, any psychiatric disorder in 95% of bulimic individuals. So, there's a lot more going on than just the eating disorder. Does one cause the other? It's an important question. Hard to know. So then, I want to shift gears. Psychiatrically, there's a lot going on that causes distress and probably could or should be treated. What predisposes teenage kids to these problems? And among those who have them, what helps us understand why some get better and some do not? I'm just going to highlight a range of areas. I don't have time to go into all this today. There are a lot of studies going on in various buckets. I'm just going to highlight the buckets. Genetics and epigenetics of eating disorders, very big. In fact, we in Sanford are in the Eating Disorder Genetics Initiative, which is an international study of GWAS-type genetic analyses in people with eating disorders, trying to understand this whole genetic risk. Biological factors, of course, are in the game. If you're not studying the brain, you're not studying eating disorders. As we were told, if you're not doing fMRI, you're not really in the game at NIH. We did just complete a full fMRI study of 50 eating disorder people and 50 normal controls in Fargo for one of the first, if not the first, fMRI study of a psychiatric population in our state. So we think we got to get there. There's a lot of other ways to obviously study the neurobiology. It's very important. Personality factors, I won't go into it, but there's a classification system based on different kinds of folks, very inhibited, obsessional folks versus very dysregulated, impulsive folks. And if you take that in and try and apply it to the eating disorders, you can get some meaningful sorting and understanding of different risks. Childhood stress. Kids who have been abused or neglected severely are at much higher risk of developing an eating disorder than kids who are not. Weight and performance-related activities. We used to talk about various track sports, running sports, gymnastics, cheerleading. They were all looked at, and there does seem to be an increased risk in certain sports for people to develop eating disorders, including in men wrestling. Sociocultural factors. This kind of is the historical heart and soul of a lot of this. It's not insignificant, it's just that it's much more than just a cultural phenomenon. There are interesting things. On the island of Fiji, a woman named Ann Becker, who's an epidemiologist and a psychiatrist at Harvard, went to Fiji for several years following eating disorder incidence rates. And she found very little eating disorder psychopathology among the Fijian girls. And then she heard about a part of the island that was going to get television. And so she said, I got to go back. That's a major social change. Her first round of studies, the rate of girls in the sample who were purging for weight control, vomiting for weight control, was 0. After 2 years after television was there, the rate of Fijian girls vomiting for weight control was 11%. Just that kind of stuff makes you wonder, how does all this work? Okay, so that's kind of the clinical background. I'm just going to get into a little bit of theory and then a little bit of empiricism and see where we land. So, in mental health, emotion is kind of a significant thing, kind of obviously, not to some people, but it was to me. I thought it was important. And so it wasn't being studied in eating disorders. We were really into cognition and behavior, and basically the person's emotional state, their sense of where they're at emotionally was not meaningful. And so 30 years ago, people started developing some of this, and we got into it, and I'll tell you how. So I'm going to focus on bulimia nervosa in this, although we've done this in anorexia nervosa, we've done it in binge eating disorder, we're doing it in other disorders, but this is the one where we launched this theoretical study which led to treatment, which led to a variety of different strategies. So the idea here, affect regulation theory, is that bulimic behaviors are elicited by unpleasant emotional states. When I'm angry, when I'm sad, when I'm bored, I'm more likely to binge and purge. Bulimic behaviors are followed by reductions. So the way you might ask, well, why in the world would they do this? Because if you ask a patient, which we used to do, we still do, they say it makes me feel less bad or better. Somehow after I binge and vomit, I feel less bad. It's like I've reset the clock. And then you ask yourself, why do they keep doing these self-damaging things? And the idea is it's rewarding. Not in a simple sense, but in a complicated way. It reduces their distress. So that's the theory. You can see it here. We built this ICAT thing, is something you'll learn about in a minute. Our fundamental idea was that stress leads to negative affective states, which in turn, in the moment, this is not cross-sectional research, this is longitudinal prospective research, but we're looking at moments of time in a given day. And this is what we said, and we said the behavior will in fact reduce negative affect. And I'll show you some data. So the first question though is, are emotions significant factors in the onset and maintenance of eating disorders? And how? How does that work? So let me just orient you a little bit, some terms for today about emotion. I'm just going to use a theory that a guy named David Watson, who used to be at the University of Minnesota, basically says emotion is a psychobiological system with 4 core components. Subjective reaction, that's what we say we feel, like I feel sad, I'm scared. There's also a physiological component, of course, autonomic, more central. There's an expressive component. I'm not going to go into it, but some people think that different emotional states have different facial expressions. I don't know. And then, importantly, certain emotional states generate behavior. Sadness may generate laying down flat on a bed. Anger might generate aggression. Boredom might generate binge eating or drinking. So these are some simple ideas about what is emotion. And then another term we use, emotion regulation. This refers to things that people do to influence which emotions they have, when they have them, and how they experience and express them. Or as another emotion theorist, Frieda, said, people not only have emotions, they handle them. And emotion regulation is about how do people handle them. And so my question when I was thinking about this years ago was, do eating disorder people have weird ways of handling their emotions? And that's what leads to their behaviors. So is there empirical evidence to support clinical research on emotion and eating disorders? 20 years ago when we were trying to make a decision, we went to the literature. There was evidence that negative affectivity or negative emotion seemed to be a risk factor for bulimia nervosa. It's a risk factor for eating pathology. Meta-analyses suggested negative affect increases before a binge eating episode. So we were interested in trying to get our head around that using some interesting technology. So it is one thing to believe that individuals with bulimia nervosa experience greater affect or affective dysregulation, so they feel worse than others. But how does it function in the development of bulimic episodes? So I'm emotional. I'm a sad, angry person, and maybe that increases my risk of having bulimic behavior. But how does it work today, Thursday, for me? And that's what we wanted to do, was kind of take a momentary approach and ask, are eating disorder behaviors triggered by emotional states? Do eating disorder behaviors reduce negative emotional states? And to test this, we need this repeated measurement system in the natural environment that gets at people multiple times a day. So real strong longitudinal analyses, but the time frame is not over 6 months. It's, when we do this, people carry our device, which I'll show you in a minute, for 2 weeks. It's called ecological momentary assessment. I don't know if anybody up here is doing it, maybe. But this is what it is. And this, in 1998, was state of the art. This is a Palm Pilot. And my colleague Ross Crosby and I figured this out, mostly Ross. And you could buy these things. We bought a whole bunch of them. And you had a software called Pumatech. And Ross figured out how to program these things. And you could put questionnaires like, this one is the PANAS, Positive and Negative Affect Scale. It's an emotion scale. And these devices would signal our participants 6 to 10 times a day, and we would ask them to complete a series of self-report questionnaires. Here's one. We asked them, tell us when you vomit, if you use laxatives, if you weighed yourself, if you exercise, did you skip a meal, did you drink fluids, did you cut yourself, did you burn yourself, did you have sex impulsively? We had a whole list of behaviors. And we were interested in looking at in the most fundamental sense, the relationship between emotional state and engagement in behavior. There were a bunch of other things in this thing. We made sure it took no more than about 4 minutes to do. Otherwise, our pilot study said they aren't going to do it. But we had 94% compliance with signals across doing 500 patients. So people found this was a doable thing. We paid them $250. We now have it on smartphones, and we use it, groups are using it around the country, real-time assessment in the natural environment. And if you need a Palm Pilot, I got a bunch, so just let me know. So this is EMA, collection of data in real-world environments, focus on current or very recent states. Phone-based assessments are triggered by telephone, smartphone. These assessments are triggered by occurrence of events. If you binge eat, and you can, take it out and record it. Predetermined time of day. We did a thing where when you go to bed at night, please push this button and it'll ask you a series of questions. But the rest of them were random signals. Throughout the course of the day, spread over, we had a nifty way of spreading it over time, somewhat randomly. So we would signal them and we'd say, if you're in the middle of a class, you don't have to do it, but please get to the next signal. And again, as I said, 94% response to the signals. So we got tons of great data. Why do it? It reduces error associated with retrospective self-reports. As someone who does clinical interviews a lot, I like to believe those are valid, but I don't think they are. If I ask somebody, how many times do you think you binge ate last week, they're guessing. That's what the literature says. And this thing is designed to get at it now. Don't give them time to distort their memory. It's in the natural environment, and because we know when we asked what questions, we can set up longitudinal analyses that truly test cause and effect relationships. So, is there a functional relationship between momentary affect and bulimic behavior? That was our first question. First paper we published, we got a NIMH grant to do this with bulimia nervosa. We ran 133 bulimic individuals through the protocol. They'd come in for psychiatric interviews. We'd do a physical assessment. We'd get some blood. We'd do some things. Then we'd hand them the device and they'd carry it for 2 weeks. So this was the first one to look at this. 2 of our patients were excluded. Their mean age was 25, Caucasian. If they had body weight less than 85, anorexic type, then we didn't have them. If they were psychotic or significant developmental disability, we excluded them. Inability to read, history of gastric bypass, and medical instability. That's how we ruled them out. Everybody else was in. This, I'll tell you what it means. This is aggregated data across all 131 individuals. This is the average curve, and this is negative affect or positive affect. This is negative affect here. This is positive affect, self-report. This is, we know they binge ate right here. And these are the emotion ratings 2 hours, 4 hours, and 6 hours before, 2 hours, 4 hours, and 6 hours after. The story is sort of clear. Negative emotional states seem to be rising right before a binge eating episode, and they drop after. Positive affect on that PANAS scale that I showed you on the Palm Pilot, is dropping before and rises after. So the negative reinforcement model that the behavior works, it's rewarding, was supported by this study. And it was the first time that had been looked at, and so we went a ways. We got several more grants. We did these with anorexia nervosa, bulimia nervosa, binge eating disorder. We kept studying this theory. It worked out for all three conditions. We published a lot of papers, over 100, using these data sets. I'm not even going to try and explain it, and there's all sorts of things you can do, you know. Let's see, that one's sort of simple. You know, we also were able to look at things like self-harm behavior, cutting, burning, banging. People report that to us. We were able to put it in the model and demonstrate, yeah, those behaviors seem to fit well in the model. Post-traumatic stress disorder. We had groups of people who had PTSD, groups who didn't. We compared their profiles. They were different. This one's in anorexia nervosa. It was a little hard to do it in anorexia nervosa, but we had two sites, the University of Minnesota and us, and we had 120-ish people who completed the protocol. Eddie Selby's out at Rutgers. He was very interested in anorexia. Nothing tastes as good as thin feels. That's his idea. That's the point. It's not about the food. It's about the affective state. We built in a lot of things about stress. How does stress figure into this model? Stressful events, you know, that kind of thing. And we just had a very, very productive line of research for a long time. So then, you know, we've got all this stuff that says this mechanism here, this emotion mechanism, seems to be something relevant to this clinical outcome. And some of us were clinically interested on the team, and it was us and the University of Minnesota and the University of Wisconsin. What are we going to do? And so at that point in time, some of you remember Jim Mitchell. Jim wrote a paper in 2007, and the take-home was the development of new treatments for bulimia nervosa should be a high priority. Terry Wilson at Rutgers said, in spite of the efficacy of evidence-based treatments, efficacy is a relative term. It's about 40% of the people who get treated with bulimia nervosa with the best treatments get better. So, but it's better than nothing. But it's still not great. But he said, even though we have efficacious treatments, we need more. So we started thinking about that, and you know, we talk a lot in this TRANSCEND world about translational research. And one aspect, I think that means a lot of things. You know, it's like, I want tissue samples, I want all this and that. But it also, and there's a lot written about this, it's about having multidisciplinary teams looking at kind of basic science data and having clinical people, scientific people, data people, others perhaps sitting at the same table trying to figure out how do we make sense of this finding and what can we do about it. And that's what we had, and we used to meet in Alexandria and stay at a hotel there and then rent a room in a cafe and brainstorm about treatment. And we started thinking about a behavioral treatment approach because for bulimia nervosa, the best evidence-based treatments were behavioral treatments. So we met for years. We did 3 separate pilot studies. So we came up with a treatment, and I'll show you, it's a protocol, a manual. It takes 21 sessions long. If you're in an NIH study, it could be longer. So we built a pilot, and each one of these had about 8 or 9 people in it. And we ran 3 waves. We ran them in Fargo, Minneapolis, and Madison. And I got to tell you, this was some of the most painful work I've ever done in my life, because we'd go out and we'd treat 8 or 9 people with protocol A, and then we'd come back and we'd say, the patients hated it, it sucked. And so then it's like, okay, what are we going to do? We got to change this, we got to change that. And then we came up with number 2, and we'd do another pilot. And we'd look at the data, and we'd interview the patients and tell us about what was useful, what wasn't. And we did that 3 times. And in the end, we applied for an R34 because we had a legitimate treatment. R34 was going to give us a pretty good shot at testing it more rigorously. And so we wrote it out of Fargo, and it was a 3-year study, and Minnesota had a subcontract. We'll talk about that now. So that led us to saying, okay, we've got this treatment, does it work? At that point in time, the best treatment in the world was a treatment coming out of England, developed by a guy named Chris Fairburn, and he called it cognitive behavioral therapy enhanced, and he had various versions of it. And so NIH told us, if you're going to do it, you got to compare it to a really good comparator. So we said, we'll take this one. And I was thinking, I don't know if we can reach that high. I don't know if we can do as well as this treatment. So that was our goal. We had 80 participants between the 2 sites, Fargo and Minneapolis. They were 18 to 55 years of age. They met DSM-4 criteria for bulimia nervosa or sub-threshold. They didn't quite binge eat enough, or their compensatory behaviors weren't enough. We took some of those folks, but about 3/4 of them met full criteria, 1/4 had a milder version of the illness. We excluded them if their BMI was less than 18. Again, you get into weight loss, anorexia deals. If they were pregnant or lactating, if they had bipolar disorder, psychotic symptoms, substance use disorder, if they were currently in another treatment, and if they were medically or psychiatrically unstable. Psychiatrically unstable in our world is, frankly, suicide risk. Participants, on average, 27 years of age, BMI was about 24, 90% female, mostly Caucasian, about half had a college degree, 73% met full criteria for bulimia, the rest were sub-threshold. Here's the comorbidity thing. It's kind of nice to see it. This wasn't an easy sample. These people had lots of psychiatric problems going on, and there were no differences in any of these characteristics across the 2 recruitment sites. The treatment, ICAT, that's ours. It stands for Integrative Cognitive Affective Therapy. Affective is the key. We put that word in there because it's about this emotion thing. It's built on the EMA. Twice a week for the first 2 weeks, then weekly. The treatments lasted 17 weeks. PhD psychologists, 2 at each site, all had previous experience delivering CBT. We trained them in how to do this new treatment. They were supervised weekly via audio tape. Wisconsin, we would look at the audio tapes, listen to the audio tapes, and we had an adherence manual to make sure they were following the manual. You can't deviate and just do whatever you want. So they were checking to make sure they were synchronized with us. And randomization was controlled by the data center, which was in Fargo, stratified by site, clinician, and diagnosis. Simply put, in green, on the left is the ICAT treatment, on the right is the comparator CBTE. Dropout rates were relatively good, 15% in the ICAT condition, 25% in the other condition. In clinical practice, a lot of people drop out. These guys hung in there pretty well. These are the change scores This is binge eating frequency over the previous 28 days. This is their baseline level. This is at the end of treatment. This is at 4-month follow-up. In this kind of research, we didn't have enough money to do more than 4 months. But it's kind of easy to get people better by the end of treatment. It doesn't mean a lot to me. The question is, does it last? And so follow-up becomes critical. Key take-home here is, both treatments worked pretty well, and there were no differences between the two. This is the purging frequency, same story. No differences, both treatments produce a change, seems to maintain at least for a while. This is eating disorder examination psychopathology. It's an overall score of kind of all the different features of eating disorder psychopathology. So it's a global measure. We administer it multiple times. And again, same story, no differences. We did then do some moderator analyses. The question is, do one of these treatments work better for certain kinds of people than the other? And we did actually find something kind of interesting here. This variable, low stimulus seeking versus high stimulus seeking. These are impulsive people, the high stimulus seekers. They're looking for action. And we measure that a lot. These people want to stay home and they're kind of compulsive and inhibited. And what we found, this is bulimic behavior frequency, and what you see is that in the lows at the end of treatment, what you see is in the low stimulus seekers, the CBT did better than ICAT, but in the more impulsive, dysregulated group, ICAT did better than the other treatment. That's kind of clinically relevant if you wanted to do precision medicine. When we looked at that overall scale, there were no differences in the low stimulus seekers, but the more impulsive group improved more on this in ICAT than in CBT. And then when we looked at another variable, affective lability, how much do my emotions move around, the low affective lability group, didn't matter which treatment they got. The more kind of moody group did better in the ICAT treatment. We published it, and the rest of the story is, oh yeah, wait a minute, yeah. We also did another grant actually studying binge eating disorder with the same 2 fundamental treatments, and we got similar findings for binge eating disorder. We looked at predictors and moderators, but the thing I want to talk about in closing is, we did some science, we built a treatment, we did an RCT, did a few of them, but how do you get the word out? How do you disseminate? We don't have a drug company running television ads at 7 o'clock at night on national television. So how do you disseminate these? It's hard. It's really hard. And getting people to believe that this scientifically based treatment is worth trying, it's hard to get some clinicians to buy into that. We gave numerous talks and workshops over the last 20 years. We did learning collaboratives, which I'll tell you about in a minute, in New Zealand, in Portugal, and we did them internationally for the Academy for Eating Disorders twice, where we bring clinicians together in groups of 20 to 40. We train them, we supervise them for 6 months on their cases, and we collect data. And it's totally not related to eating disorders. It is North Dakota. This is where we learned this thing about learning collaboratives. In the early 90s, I went around the state and talked to mental health centers and all the big centers around and asked, how many people do you have here that can treat traumatized children who have signs of PTSD? And there were 2. There was one in Grand Forks and there was one in Minot. That was it. And so we built a training program for how to train clinicians using this learning collaborative model, where we bring them together, get groups, train them up, and then supervise them for 6 months. We did it in the state of North Dakota, and we've been doing it. It will be 20 years next year. And we now have 800 trained mental health clinicians who can at least have an idea what to do with a traumatized kid. That's the model we used in these studies. It's just easier to do when it's just one state. If you're trying to do it nationally or internationally, it's really complicated. So the take home is, even if you have a treatment that looks promising based on the science, getting it out there and getting people to use it is a challenge. In conclusion, basic translational research using EMA may help to elucidate maintenance factors like affective state. Translational teams can build treatments that target these maintenance factors, and clinical trials and implementation science may ultimately bring scientifically informed treatments to our patients. That is all I have. Questions? Yes. Sure. I don't know if you could hear it. The tail part, which I'll address, and then I'll go back and talk about the culture of wealth. The question at the end was, is there anything in the genetic studies which helps us to identify factors which might be useful? Not so much. Some of these single gene studies that were being done 15 years ago thought they had all sorts of ideas, hasn't panned out. The GWAS studies that are being done, preliminary data, did find one, I think, important thing. They found a particular chromosomal genetic abnormality which predicts psychiatric problems, and they found another one which predicts metabolic problems. So increased chances of obesity, increased problems of anything related with metabolic difficulties. Both of those seem to be elevated in individuals who have, in this case, anorexia nervosa. So now it's being touted as a metabolic/psychiatric condition. And if that holds up, that's useful. So we'll see. The studies need to get done. I'm not a GWAS person, but the sample sizes in these things got my attention, that's for sure. In terms of the culture of wealth, and you got to have money to be able to binge or diet or things like that. I think it's largely true. If you go into the Mideast and look for eating disorders, it's hard to find them, probably for a multitude of reasons. The one thing about binge eating seems to have jumped the cultural fence. And in fact, low-income kids are now binge eating as much or more than high-income kids because they're getting all their food at Stop and Go. And they just eat. It's the garbage phenomenon. And that, in fact, we did some studies with some people in Montana. Anorexia nervosa is not prevalent on the reservation out there, but bulimia nervosa and binge eating disorder are. So there's some things about SES which are just as we expected, and there's a few that are catching us off guard. Jonathan.
Not one word about pharmacotherapeutics in this talk, which almost certainly complicates every aspect of what you're doing. So, and now with GLP-1 blockbuster drugs, can you without giving another 1-hour seminar, but can you give us some idea of how drugs which have come and gone have complicated your life's work? And of course the people that are suffering from it.
Yeah. I don't know if it's complicated my life's work. In bulimia nervosa and binge eating disorder, SSRI antidepressants are useful for a period of time, but they don't promote full remission. It's rare. And when the people stop taking them, the behaviors tend to return. The thing about anorexia nervosa, and trust me, everything from THC to antipsychotics to antidepressants to anticonvulsants have all been tried, and nothing has been shown to be effective. There is not an empirically supported pharmacotherapy regimen for anorexia nervosa. And that kind of is disturbing. So, in fact, in our trial, people could come into our trial if they were on a stable dose of whatever drug, our treatment trials, and they'd been at that dose for at least 2 months. Then we said, yeah, come on in. Let's see if we can do anything else. So pharmacotherapy has a real place in the eating disorders. We have to be able to treat mood and OCD and all kinds of things. The one, though, that catches my attention just goes to your point. Anorexia nervosa, there is no empirically supported treatment for anorexia nervosa if you are 17 or older. Behavioral, pharmacologic, family therapy, aromatherapy, there's nothing. So the data is clear. It is, at this point, an untreated condition. And it's the most, in my mind still, the most lethal psychiatric disorder, and we've got nothing. If you get them early, 16 or younger, and you put them in family therapy for about a year, they get better. But not once they're older. So I don't know. I don't know what to tell you. Yeah.
In terms of dissemination of your scientific findings to clinical practice, what are the challenges you've faced in terms of trying to reach out to clinical practitioners?
What are the challenges of dissemination? Simply put, there's not an infrastructure to do it well. So, I run to Portugal and train a bunch of people and then supervise them for 6 months, and we do it. But then how do you get it out? And how do you get people actually doing it in their practices? The biggest problem I think we have is what we call the science practice gap. And many of our practicing clinicians are kind of like, look, I've been doing this a long time. I know what to do. Don't worry about it. I don't need your new treatment. And we've done a few of these learning collaboratives with practicing clinicians from all over the US, and they enjoyed it, they took part in it, but it didn't change their practice patterns. There's a lot of other factors, I think, controlling that, including money. Kent, I don't know, am I supposed to stop?
Anybody have any more questions today? Well, thank you everyone for attending this afternoon. And again, thank you, Dr. Wonderlich, for your amazing presentation.